Okay, hi, good evening to all. A very warm welcome to Teacher Learn Classes. We are back with the ninth webinar of the season. Today, we'll be having the first session on ECG. So this time ECG class has been divided into two, part one and part two. This part one class will cover the basics of reading an ECG. We have an excellent speaker for this session. It's none other than Dr. Chaitanya, who is an assistant professor in the Department of General Medicine and a DRNB resident in hematology at St. John's Medical College Hospital. I know that he does not require any further introduction. He has a winning streak of getting the Best Teacher Award the past many years now. He's there for you for clearing all of your questions, doubts, worries, however silly it is or whatever the time of the day it is. He's the most precious teacher that we all could have asked for. I wholeheartedly welcome you, sir, to this class. So before we start the session, a few reminders. Please keep yourself muted throughout the meeting. If you have any queries, please type them in the chat box, or there's a WhatsApp group, as you all know. So you can put it up there. For those who have not joined our discussion WhatsApp group, I can also put up a link in the chat box. We'll be using that group for all the discussions related to teacher learned classes. And also we'll be putting up a feedback form in the chat box as well as the class, the WhatsApp group. Please make sure you fill that. It will really help us in improving the next sessions. So please do that. So over to our speaker now.
Hi, good evening, everyone. Thank you, Namita. That was a very generous and very kind introduction. Thank you so much. I hope the slides are visible.
Yes.
They're changing. They're going. Okay. Right. So good evening again to everyone. Welcome to webinar number 9. So I think Namita and I discussed this and we decided that we'll split the ECG into two parts. I thought I'd do part 1, which is how to read an ECG, and then part 2 would be to discuss certain common ECGs that all of you would encounter at some point of time in your rural practice and then your practice henceforth. I've sort of tailored that to what I would expect you all to see in your practice. So therefore, it becomes much easier. But before we read into diseases, etc., until we know the basics, until our foundations are strong, it doesn't really make sense to go into more detail. So that's why I said we'll divide it into two parts. So coming to part 1, which is basics. So as we all know, over the years, ECGs have evolved. The left one is the left pictorial on your slide is showing how probably ECGs were first detected. Slightly inaccurate with somebody listening to the heart and then jotting it down. But then we've progressed from there to the standard 12 lead ECG. All of you who worked have seen this ECG. All of you have used it at some point of time. It's still this gold standard is the 12 lead ECG that we use, the machine that you see here in various forms. But what I put in the bottom right is the Apple Watch, and there are a lot of smart watches, smart gizmos and gadgets now, which can detect a basic ECG right off your radial artery. And I've used a couple of these devices on patients. I've seen how they worked, and they're surprisingly accurate. Of course, there are the variations and the variabilities are high, but these are enough to at least tell me, especially for life-threatening arrhythmias. And I've had 1 or 2 personal experiences with patients who, in fact, sent me an ECG strip from their watch and have been able to pick up that there are some changes and then got them evaluated and henceforth. So are we going to replace an ECG with a watch? Definitely not. A standard 12 lead ECG remains and will always remain the gold standard. But this is something that we can also keep. So the outline of today's presentation is basically I'm going to teach you just a few diagrams on the basics of cardiac electrophysiology. All my slides are filled with pictures. There are almost no theory today. How to place the leads, and this is very, very important because a lot of students work in centers where the ECG training may not have been as good for the staff. So it's important for lead placement because a lot of ECGs come to me where the lead placement is faulty and thereby a diagnosis is mismade or misdiagnosed rather. The ECG checklist, which I think is the gold standard for any doctor to follow, ensures that you can pick up 90% of all findings. How to interpret an ECG, that's the ECG reading basics, and a practice session to culminate. So if you look at the basics of cardiac electrophysiology, and I advise that every student who goes through this, I'll be sharing the slides, of course, looks at this, because once you understand how the cardiac conducting system works, ECGs become very, very easy to read. So as you all know, we have a pacemaker, which is right in the SA node. This pacemaker is the one that sets the impulse of the heart. Please remember, every myocardial tissue has the potential to be a pacemaker. So that means every cell of the heart has the potential to be a known pacemaker. But the SA node cells become the predominant pacemakers and overshoot all the other muscles. But if your SA node is dysfunctional or certain parts of your myocardium become hyperfunctional, they can become potential pacemakers leading to arrhythmias like atrial fibrillation. So it's important to identify these, which we'll which we'll discuss in the subsequent class. The SA node sends impulses to the right atrium and the left atrium, causing the atria to get stimulated, electrical stimulation. Impulses then pass through three pathways, Thorel, Wenckebach, and Bachmann to the AV node. The AV node is like a gate, so it sort of delays the impulses by a fraction of a second, which allows the ventricle to relax and receive as much blood from the previous cardiac diastole. Then the ventricles are innervated. You have a common bundle of His, which goes into a right bundle branch and a left bundle branch. This goes through the myocardial fibers and distributes electrical impulses to each myocardial fiber through the final division, which is called the Purkinje fibers. So you have SA node to right and left atrium, SA node to the AV node, slight delay at the AV node. AV node goes to the common bundle of His, which divides into a right and left bundle branch, and then the Purkinje fibers. So this is how electrical impulses are conducted 72 times every minute to the heart. Now, the left is the same diagram, of course, which shows you what I discussed in the previous slide. But what's on the right is very, very important for us to know is this is how an ECG pattern looks in relation to the cardiac events. So when you look at the SA node, so remember all cardiac cycles start with the SA node stimulating the atria. So if you look at the SA node, the current is coming out from the SA node, which stimulates the two atria. You'll notice that once the electrical impulses reach both atria, it generates the P wave. I'll come to each wave subsequently. And that's the first wave that any ECG records. And please remember, an electrocardiogram or an ECG is a representation of the electrical events in the heart, which are then succeeded by the physical contraction of the heart or the mechanical events in the heart. So never say P wave corresponds to atrial contraction. P wave corresponds to atrial electrical activation. So that's a subtle difference that you need to make when you report an ECG. So the atria are represented, as we know, by the first undulation that we see called the P wave. Then you have the AV node, which is then stimulated. That is the PR segment or the PR interval. That's the time taken for the SA node to send impulses to the AV node. The AV node then innervates the common bundle of His, the right and left bundle, and that generates the fantastic and the famous QRS complex, which is both ventricles being stimulated. And the QRS complex varies in shape based on which ventricle is innervated, which we'll come to subsequently. While the ventricles are being depolarized, which is ventricular activation, the atria are being repolarized. And that event is hidden in the QRS. You will never see a wave representing atrial relaxation or repolarization. And then you have the terminal event, which is the formation of the T wave. The T wave is when the ventricles have finished relaxation and the impulses are reaching the valves, actually the papillary muscles of the valves, and that's when your ventricular depolarization is complete and your ventricular repolarization occurs. So ventricular repolarization is represented by the T wave. So you have P, which corresponds to atrial activation, QRS, which is ventricular activation, and T wave, which is ventricular repolarization, which is extremely important to know. So if you go in this particular format, you will never miss to understand how an ECG works. So this is a similar diagram showing the same thing. If you look at how it's stimulated, this again shows the breakup of the waves with the symbols. Coming to lead placement. So now that we've understood how the heart is innervated, let's look at the lead placement. So as we know, we do a 12 lead ECG, and a 12 lead ECG consists of 6 chest leads and 3 limb leads. The 3 limb leads are further modified into augmented limb leads. So we get 6 chest leads and 6 limb leads together as 12. So the lead placement on the chest is in the box, as you mentioned. Now, one thing I'd like to bring to everyone's notice is that very important to know that V4, V5, V6 should be in the same line. Commonly, V5, V6 gets misplaced, and that is where you get a lot of abnormal readings. As mentioned in the box, V4, V5, and V6 should be at the same level throughout. So it's not in the intercostal space, they should be in the same level. And the most important reason that this has to be accurate is so that you don't miss certain lateral wall changes, which I'll come to when we deal with the subsequent MI. So V1 is in the right fourth intercostal space, right of the sternum. V2 is on the left. V4 is at the fifth intercostal space in the mid clavicle line. V3 exactly in between V2, V4. V5 is at the anterior, and V6 is at the mid axillary point. And it's important to note that they have to be in the same straight line. So the chest leads basically give us one horizontal cross section when we look at the heart. This is another example showing the chest leads. Coming to the limb leads, and this is where I want all of you to pay a little bit of attention. The limb leads are important to understand that ideally when you take an ECG, this is how your placement should be, right? When Einthoven first formed the Einthoven triangle, which is the basis for any ECG, he actually had connected the leads to the two shoulders and the ankle. In fact, not even the ankle, in fact, it was connected to the left hip. But because they were present at bony prominences and very uncomfortable, we basically shifted it to outstretched hands and the left foot. The objective being that the heart should be roughly in the center of this inverted triangle. But if you notice, all of us, when we take ECGs, our patients never keep their arms out this way. Our patients' hands are always by their sides, which means the arms come somewhere near the pockets. So ideally, that's not the most accurate way to do an ECG, but that's the best way to do it in our setting. So you have connected to the right wrist, connected to the left wrist and the left ankle. All of you might have seen while connecting an ECG that there's also another one connected to the right ankle, which is the earthing lead, which is not of much significance in this scenario. So we place one lead on the left right wrist, one lead on the left wrist, and one lead on the left ankle. So if an impulse goes from the left wrist to the right wrist, that becomes lead 1, which is Roman numeral 1. The impulse from the left wrist to the left ankle is Roman numeral 2 or lead 2, which is one of the most critical leads to see. And from the left wrist downwards to the left ankle is lead 3, which again is from up down. So these are the standard limb leads, and these are the leads which basically measure the difference in electrical potential from the 2 points that are mentioned on the diagram. But if you look at the augmented leads, so basically these are 4 leads where the center point is actually where the heart is supposed to be. It's the center of the triangle that's created, which is actually not where the actual human heart is, because this is a modification of Einthoven triangle. But this is the center of where a triangle where the heart is supposed to be, and it measures the impulse between that and various leads. So the distance between the middle and the foot becomes AVF, F for foot. Between the left wrist becomes AVL, L for left, and AVR for right. So by using a mixture of 6 limb leads, that is 3 standard and 3 augmented, and 6 chest leads, we get a 2D construction of the heart. And this two-dimensional construction of the heart helps us track the cardiac vector. Now, what do I mean by the cardiac vector? It is the net electrical impulse that goes from the SA node to the AV node to both ventricles. And all of you should remember that the cardiac vector generally goes from right to left, from right shoulder towards the left foot. The reason is the right atrium is towards the right shoulder. And in the ventricles, the left ventricle is 3 times the size of the right ventricle. So the net impulse is always towards the left. And if you look at it physiologically, this goes along lead 2. So right wrist to left foot is along lead 2, which is why lead 2, if anybody asks, is the most electrophysiological lead in an ECG. So this is how lead placement is done. Coming to the checklist. Now, why do we harp on this checklist? An ECG checklist is basically done for us to look at what a doctor needs to look at when they're dealing with an ECG. Now, normally you get ECGs on WhatsApp, you get ECGs right in front of you. There's a lot of ways in which ECGs come to you. And often what happens is when you see large amount of abnormal rhythms on the ECG, it causes a lot of stress, right? And often your first thing is you're looking for an MI, you're looking for ST elevation. You don't see that, but you know there's something abnormal. You're not sure what it is. It creates a lot of stress. If you follow an order, if you follow the checklist, and you follow this particular order, which is quite easy to eyeball, I guarantee that 90% of the time, you will not miss something major. right? There are a lot of things that we are still learning when we read ECGs, right? And the only way to master an ECG is to keep reading them. But if you follow this checklist, you will never miss out on an abnormal finding. So the first thing to look for in a checklist, and I'll be dealing with this in detail when I talk about each part, is the standardization. I'll come to what that means. Looking to see if the ECG has been connected correctly. I've had bonders send me ECGs where the ECG is not being connected correctly, led to an abnormal ECG rhythm, which has led to a misdiagnosis. Touch with the bonder reached out, and I was able to tell him, okay, him or her, that okay, this is what needs to be done. Repeat the ECG with this calibration change, and it turned out that the ECG was normal. But in that 15 minutes till this got done, both the patient and the bonder were extremely stressed. This is something that is very correctable at a basic level. Then you look at the rate, which is the most important. You look at the rhythm, whether it is a sinus rhythm or not. You look at various intervals. You look at various axes. You look at the P waves, the QRS wave, and the T waves. Look for the famous ST segment and compare with the previous ECG. Now, I'm not going into each of these in detail because I'll be coming to them when I discuss each part. But if you can eyeball an ECG and follow these 16 points, you will never go wrong. You will never miss a major finding. Yes, a rare arrhythmia is something that which you don't know. You'll at least be able to identify, is this an arrhythmia or not? I need to do this and refer the patient. But you will not miss, and especially missing an MI is definitely something that could cost the patient his heart or even his lives. Right? So this checklist is something that I request all of you to follow. It's quite easy. It's made by our medicine department. So once I share the slides with you, take screenshots of these 3 slides, keep it with you. You will never miss an ECG. So coming to the crux of today's class, which is how do you interpret or read an electrocardiogram? Something I probably should have said at the beginning of the class is, why is this essential? Why is this so important? It's because in your career, whether you become a biochemist, a ENT surgeon, a gynecologist, a physician like myself, a neurosurgeon, a dermatologist, it doesn't matter. ECGs will always come to you at some point. Whether it is your family members, friends, patients, colleagues, you students, you will always get ECGs no matter what caliber of doctor you are. Because everybody panics when they have chest pain, right? And you will get ECGs, and your duty at that point is to tell them what to do. Nobody's asking you for a spot on diagnosis, but they're asking you for help. Do I need to go and get this checked out? And your answer has to be, yes, I think you're having an MI, rush to the hospital. Or, yes, I think you're having an arrhythmia, visit your cardiologist. So I think that this is one of the most basic arts in medicine that we should all know, irrespective of what field you take. Hence the importance of ECG. So when you interpret an ECG, you need to interpret it as per the checklist. This is the breakdown of the checklist. You will never read an ECG without checking if it's technically correct, whether the calibration is correct or standardization is correct. Never look at an ECG. If the standardization is wrong, make them repeat the ECG. It is worth doing that rather than erring when you read a ECG which is not calibrated. Once you've established that this is a calibrated standardized ECG, you calculate the rate that tells you bradycardia, normal rhythm or normal heart rate or tachycardia. Look at the rhythm. Is it a sinus rhythm? Is it an abnormal rhythm? Is it an atrial rhythm or a ventricular rhythm? Look at the axis. Is it normal axis, left, right, or extreme? Look at the P wave, the QRS, and the T. Are they all occurring normally? Look at the ST segment and the PR segment. And finally, the QT and PR intervals. Only when you have gone through all these 8 things can you say ECG is normal sinus rhythm or ECG suggests acute MI. You have to go through all of these because each step is critical. So coming to the standardization, and this is probably the most important thing I keep stressing on, which is calibration or standardization. Now, irrespective of what system you use, whether it's an iWatch or a smartwatch, whether it is a 12 lead ECG machine, your ECG paper has to move at a speed of 25 mm per second. It is absolutely essential. If your speed is faster or slower, you will misinterpret the rate of the ECG. The second is the calibration. And you look at this box that's there, it is there in every ECG to the bottom left. Before every lead, before the wave of complexes are read, you will see this. And if you look at it, you will see that there's ECG paper in the back. So 2 things to observe. One, speed 25 mm per second to this particular box. Now, how do you look at this box in the book? An ECG paper is divided into multiple boxes. There are two sizes. You have small boxes or small squares, which are present, and you have multiple small squares together forming one large square. Because the speed is 25 mm per second, each small square, which is 1 millimeter in width and height, each small square is 0.04 seconds. So 5 small squares becomes 0.2 seconds. That is equal to one large square. So if you look at one large square, it should have 5 small squares, and its duration is 0.2 seconds. Therefore, 5 large squares becomes 1 second. Okay, so 5 large squares becomes 1 second. Similarly, if you look at the height, which is a measure of the amplitude of the waves created on an ECG, every small square is 1 mm in height. 5 small squares becomes one large square, which is 5 mm. 2 large squares becomes 10 mm. So this box has to always be one large box in width and 2 large boxes in height. That is 0.2 seconds in width and 10 mm in height, which is equal to 1 millivolt of ECG amplitude. So this is a normally calibrated or standardized ECG. If you don't see this, do not interpret the ECG, you will run wrong. Because if the amplitude is less, your complexes will look smaller. If the width is more, the rate goes all right. So it has to be 2 big squares in height, 1 big square in width. So if you look at this particular ECG, in fact, it is wrong because it is only 3 small boxes in width. It should actually be 5. But this is a slightly stretched ECG. This is the correct one. 5 small boxes in width and 10 above, or 1 big box in width and 2 above. This is critical. Why am I harping so much? Because it makes a difference in how you read this ECG. Okay, so 25 mm is actually 1 second, and in 1 second you will get 5 big boxes in width, and each big box is 5 mm in height. So this is called calibration or standardization. Now, why am I harping on this? You will see in the next slide. This is a standard ECG that is taken. All of you look at ECG and okay, this looks normal to me. What you have to look at first is what the red arrow shows. This is normal calibration. Can you see that? It is approximately 2 big boxes in height and 1 big box in width. This is a must. This is an absolute must for every ECG. Do not proceed with ECG reading unless you see this. Why am I harping on it? This is the reason. Look at the ECG on your left. The problem is the height is okay. It's about 2 big boxes in height, but the width is more than 1 box. It is 2 big boxes, because of which all the complexes look stretched, all the intervals are prolonged, all the segments are stretched. So this is abnormal. So you will misread this as wide QRS bradycardia. On the opposite ECG on the right side, the calibration is too thin. The height is okay, but it is too thin. And because of that, the heart rate looks higher than it is, and the complexes are all narrow. So you will misinterpret based on this. So can you see how much of a difference the calibration makes? Please always check the calibration before you read an ECG. Right? This is how it should look. So if you look at the same ECG in 3 parts, the first part is how a normal ECG looks. You look at it, it's about 2 boxes in height, slightly more than 1 box in width. If I make the height only 1 box instead of 2, the complex becomes shorter. If I make the height longer, the complex becomes bigger. So therefore, you may mislabel this as a low voltage complex. You may mislabel this as chamber hypertrophy and make a wrong diagnosis. So you have to look at the accurate calibration. Right? This is with regard to the calibration standard. With regard to the speed, the ECG at the bottom, the speed is with 25 mm per second. This is the routine speed. The same ECG, if I make the speed 50 mm, you see how the complexes get stretched. So this is a change that will occur if you stretch the ECG. So what you will do is you will miscalculate the rate. When I talk about rate calculation, you'll figure out. Rate calculation is 300 divided by the number of big squares. The rate is 75. But here, if you did 300 by the number of big squares, you would get a very low rate. You'll say, oh, this is bradycardia. That actually, because your speed is wrong, your heart rate is wrong. I remember an incident about a couple of maybe 3-4 years ago, just during COVID, where somebody had sent me an ECG with the speed of the paper at 50, and the patient had had a heart rate of 40. They gave them atropine, and when you give atropine to a patient who is absolutely normal, they can develop some psychiatric manifestation, and the patients start getting aggressive, etc., because of the atropine. And the heart rate, when they did the manual heart rate, it went up to 150, and then they had to give a beta blocker, and they had to restrain the patient. So it became quite a mess purely because the calibration was abnormal. So you have to be very careful when you. So point one of ECG is done, which is standardization. Next, so standardization and paper rate. Next one, which is rate calculation. Now, this is something that all of us tend to take for granted. Be very careful. When you're in a busy emergency casualty or in a busy OPD, which all of you are involved in, calculating the heart rate becomes a little tricky. Ideally, you should never calculate the heart rate in any lead except lead 2. If you remember in the beginning of this class, I said that the most physiological lead is 2 because it's in the direction of the cardiac vector, and it accurately represents the sinus innervation of the heart. So when you look at lead 2, all our 12 lead ECGs, as you would have noticed, at the bottom of the 12 lead ECG, they have a lead to rhythm strip. A rhythm strip is basically about 10 seconds worth of complexes in lead 2. Minimum of 10 seconds, ideally it should be 30 seconds, but a minimum of 10 seconds worth of complexes only in lead 2. So look at that, look at lead 2 and take two positive waves. So in a QRS complex, the positive wave is called the R wave. So look at the R waves, take two consecutive R waves, okay, and count the number of boxes between the two R waves. If you are able and you're patient enough to count the number of small squares, each tiny square I said is 0.04 seconds. So count each tiny square between the two R waves, divide 1500 by that, you'll get a heart rate of the patient. This is provided the speed of the paper is 25 mm per second. Very important. Again, calibration makes a difference. If unfortunately you're not able to count each small square, you don't want to strain your eyes, then you can take the big squares. Take 3, the formula becomes 300 divided by the number of big squares. So if you're using the large squares, count the number of large squares between two successive RR intervals, divide 300 by that. So here it's approximately 5 and odd boxes. 300 divided by 5, approximately 55 to 60. This is the best way to calculate your heart rate. Ideally, it should be 1500 by number of small squares, but since we can't do that in all patients, 300 divided by that. Now you'll wonder, sir, why have you put up the last one? The last one is because not everybody will have a normal sinus rhythm. Please remember, here you are having a normal sinus rhythm, that PQRST, PQRST, PQRST. Some patients may have AV blocks. Some patients may have atrial fibrillation, where the heart rate is awfully irregular. What do you do then? Because the RR interval in such patients will vary. In atrial fibrillation, every RR interval is different. So if you take RR of two successive R complex, you make it a heart rate of 40. The next complex heart rate may be 160. So atrial fibrillation, you cannot calculate with this formula. So what do you do then? As I told you, at the bottom of every ECG, lead to, there are about 10 seconds worth of complexes are there. So in 10 seconds, which is about 50 large boxes, you count the number of R waves, not the RR interval. You count 1, 2, 3, 4, 5, 6. You count the number of R waves. In 10 seconds, if there are 9 R waves, in 60 seconds, which is 1 minute, there will be 9 into 6, which is 50. So you can do this in patients where you have an irregular heart rate. So patients who are not in sinus rhythm, irregular heart rate, 10 seconds worth of complexes and lead to count the number of complexes, multiply by 6. So this is how you calculate the heart rate in patients in an ECG. This is the example. This is the ECG. What is step number 1? Not rate calculation. Step number 1, look if the calibration is normal. 1 large box wide, 2 large boxes tall. Perfect calibration. Next, heart rate. Take lead 2. The rhythm is quite regular. Count the number of large boxes between the two. So if you take this 1, 2, 3, 4, 5, 6, 7, 8. So there are 8 large boxes. So 300 divided by 8. So your approximate heart rate in this patient is about 37 odd. So it's less than 40. This is severe bradycardia. So you got it? So you're dividing 300 divided by 8. Right? So this is how you are supposed to calculate heart rate in a regular patient. But never forget to look at the calibration. Right? This is the formula that we apply. Look at this. This is a patient with tachycardia. The heart rate appears high. First, we'll always look at the calibration. One wide, two tall, perfect. Take lead two, right? Calculate the number. So there are approximately maybe two, little more than two big boxes. So 300 divided by about two, the heart rate is in excess of, it's about 150. So 120 to 150 is the heart rate, roughly about 150, which means this is tachycardia. So this is how you calculate heart rate. Two RR intervals successively in lead two, number of big boxes, 300 divided by the total number of big boxes gives you your heart rate, provided calibration is normal. Right? Now, this is the third example. Heart rate is irregular. Can all of you see how irregular the heart rate is? This is a rhythm strip of lead 2. If you look at the bottom, the RR interval is so different. If you calculate the RR interval between these two, and you calculate the RR interval between these two, and you calculate between these two, all three will give a different heart rate. So it is very difficult to calculate. So in this setting, you take the rhythm strip, which is approximately 10 seconds, count the number of complexes that occurred in 10 seconds. So the number of complexes are 1, 2, 3, 6, 9, 12, 15, 18, 17 to 18 complexes in 10 seconds. Multiply by 6, you get the total amount of heart rate, which is approximately 108. So your heart rate here is 108, right? So this is how you calculate when the heart rate is irregular. Okay, this applies the third formula that I mentioned. So good, we are 2 steps down. We finished calibration, we have finished rate, we are 2 steps down. Step number 3, rhythm. So what do you mean by rhythm? What is the importance of rhythm? Why are we looking at, rhythm? Rhythm means very simply, is the heart rate in sinus rhythm. Sinus meaning, is it from the sinoatrial node? Whenever we talk about the word sinus rhythm in ECG, we mean, is it in the sinoatrial node rhythm, which means SA node stimulating atria, SA node to AV node to bundle of His, right bundle, left bundle, Purkinje, innervating the heart. That means, how do you make it out in ECG? In an ECG, if you look at lead 2, again, the most physiological lead, you should have SA node to AV node, P wave and PR segment, stimulation of AV node, bundle of His and ventricle, QRS segment, followed by T. Every complex in the ECG, P QRST, P QRST. It should follow that rhythm. You can't have QRS PT. You can't have QRS PP. That's an abnormal rhythm. P QRST, P QRST. So if you look at this ECG that I've shown you, you will see there is P, which is an indication that the SA node is stimulated the atria. QRS, AV node is sent to bundle of His and stimulated the ventricle, and T waves, ventricular repolarization. This order means the patient is in sinus rhythm. Anything else, mention the rhythm is abnormal. Say you're seeing QRST, no P, abnormal rhythm. You're seeing QRST, P is after T, abnormal rhythm. So very simply, P QRST in all complexes, of course, you look at lead 2. Then you can comment sinus rhythm. But before this, what should be correct? Calibration. If you look at the calibration here, it's quite narrow. So this calibration is actually a little off. It should be one wide and two tall. So look at this abnormal ECG. I put 2 ECGs on top, right? If you look at it, the rhythm is abnormal. You can make out that the RR intervals are very irregular. This one is 2.5 boxes. This is 3. The rate is irregular, but the rhythm is also. You cannot make out a PQRST complex synchrony. If you look at the complex here, this is P, this is T, this is P again, another P. So this complete chaos in this ECG. So if you look at what I've marked with all the red arrows in this particular ECG are all the P waves. Can all of you see that? You can see the P waves. So you have P, 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 P. And the QRS is the wide complex in between. You will see that every P is not necessarily followed by a QRS or vice versa. Not every QRS is preceded by a P. If you look at this complex, there's a P is here, the QRS is here. If you look at this complex, the P and QRS are so close to each other. So this is definitely not a sinus rhythm. So when you look at this, you mention P and QRS are not occurring in synchrony. This means the patient is not in sinus rhythm. And this is very, very important. You look at this particular ECG that I've shown. The bottom one just looks like a child has scribbled on a piece of paper, or in some cases, some adults like myself whose handwriting hasn't evolved over the years, my handwriting tends to look like this. The bottom ECG. It just looks like a squiggle where you can't make out head or tail. You can't make out any defined complex. Definitely, this is not sinus rhythm. In fact, this is probably VT or polymorphic VT. You look at the ECG on above with all the red arrows that I've put. Every red arrow is a QRS, and it's occurring regularly. There is QRS, 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 but there are no P waves. So even though this is occurring regularly, the rhythm looks regular, it is not sinus because there is no P wave. You have to have P, QRS, T. Anything which is not in the P, QRS, T sequence is an abnormal rhythm. This is probably PSVT. The bottom is polymorphic VT. This is basically complete heart block. This is probably flutter fibrillation. So you are looking at abnormal rhythms. The basic point, these are not in sinus. Calibration, rate, rhythm. 3 down, 5 to go. The next is axis. Now, why do you want to know the axis? You said that, sir, anyway, you said right arm to left foot. That is normal axis occurring along lead 2. But when the heart enlarges, right, as the myocardium thickens and becomes larger, or the ventricular conduction system becomes faulty, some parts of the heart may get innervated faster or more than other parts, changing the axis of the heart. And this change in axis reflects two things. Either the chamber is enlarged and become thicker, so more electrical activity, so the vector has changed, or one of the connections to the ventricle, which is your bundle branch, has become slow. Only two things cause a change in axis. So normally, if you look at the heart, we look at two leads. We look at lead 1 and we look at AVF. Lead 1 normally goes from the right arm to the left arm, and AVS goes from the center of Einthoven's triangle to the foot. So the normal axis of the heart is from right to left, which is exactly between lead 1, which is horizontal, and lead 2, which is AVF. Right? Anything else is up down. Ideally, the axis is looked along lead 2, and lead 2 perfectly bisects between 1 and AVF. But ideally, the axis lies anywhere between 0 to 90, which is between lead 1 and AVF. So when you want to eyeball an ECG and look at the axis, you only need to look at two leads, lead 1 and AVF. So I'll give you an example. When you look at lead 1, look at the QRS complex in lead 1 and see if it's predominantly up, where it's called positive or upright, or predominantly down, where it's called negative or down. Look at the same thing in AVF. If lead 1 is positive, which means the impulse is going from right arm to left arm, it is positive, it's upright. In AVF, if it goes from the center of the triangle to the foot, if it's upright, it is positive. If both are positive, then the axis lies in the normal axis. That is, a positive deflection for lead 1, a positive deflection for AVF means normal axis. If lead 1 is positive, that is, this goes from negative to positive, but AVF is negative, which means it's going away. From here away, it falls under left axis deviation, where lead 1 is positive, AVF is negative. Let's say lead 1 is negative, that the impulse is going away from the left arm this direction, but AVF is positive, going towards the foot. The axis is called right axis deviation. And very, very, very rarely, both are negative. It's going away from lead 1 and AVF. This is called extreme or northwestern axis. It is very rare. It is usually because the leads are connected wrong. If the leads are connected right, there are only two causes for your level for extreme RAD. Cor pulmonale, which is right heart involvement because of a lung disease, or VTAC. Right? Only two causes for extreme right axis deviation. Right? So which are the two leads we look at? One in AVF If the QRS complex is predominantly positive in both, it is normal axis. Predominantly positive in one, and negative in AVF, left axis. Predominantly positive in AVF, but negative on right axis, both negative is extreme right axis. So looking at this ECG, always look at the calibration. One wide, two tall, absolutely fine. What are the two leads that we focus on? We look at the QRS complex in lead one. It is predominantly upright, positive, good. Look at AVF, it is predominantly negative. So one is positive, AVF is negative. This basically becomes left axis deviation. If you go to this slide, it is left axis deviation. The commonest cause of left axis deviation is usually a left anterior hemiblock. So as I said, there's a right bundle branch and a left bundle branch. The left bundle branch has an anterior division and a posterior division because the left ventricle is so thick. If the left anterior division of the left bundle branch is slow, you get a left anterior hemiblock, which presents like this. The other causes of left axis deviation include pregnancy, systemic hypertension causing left ventricular hypertrophy, and left anterior hemiblock. This is left axis deviation. This ECG calibration is normal. If you look at lead one, you have a positive and negative wave, but it's predominantly negative. So lead one is negative going away from the left arm. AVF is positive. So this becomes right axis deviation. The commonest causes of right axis deviation are usually right-sided heart enlargement. So right ventricular hypertrophy due to cor pulmonale, pulmonary stenosis, pulmonary artery hypertension, tricuspid, tricuspid regurgitation. All of these can cause right axis deviation. And this is the one you have to be very, very careful on. Lead one, predominantly negative. Though you have a positive wave as well, the predominant wave is more negative. AVF is also negative. And I told you, if both are negative, the axis is northwest or extreme right axis, which is a very rare phenomenon. Whenever you see this, always look at AVR. Because in these two leads, if one is negative and AVF is negative, the axis is going towards the right shoulder. And AVR is the only lead which is at the right shoulder, and it's the only lead which is always negative. The P is negative, the QRS is negative, and the T is negative. So if your axis is truly towards the right shoulder, AVR from becoming everything negative will become everything positive, which is a very, very, very rare phenomenon. So look at this ECG. Everything is positive in AVR. And if you look deeper at the ECG, I have circled V4, V5, V6. Normally, V4, V5, and V6 lie over the left ventricle, and they should be nice, tall, positive R waves. But here there are smaller, smaller, smaller negative waves. So whenever you see this ECG with extreme right axis deviation, AVR positive, and very small waves as you go. Normally the R waves as you go from V1 to V6 become taller and taller because they represent the left ventricle, which is larger and larger. When you see the opposite, the R wave is becoming smaller as you go from V1 to V6. This is called reversal of R wave march. If you add that to right axis deviation in a positive AVR, this is dextrocardia. This gentleman's heart is on the right side of his chest wall. And because of that, that's the other cause of right axis deviation apart from the ones I mentioned before. So very interesting ECG to look at. Calibration, rate, rhythm, axis. We are halfway through, and now we come to the fun, fancy part where all of you make the fancy diagnosis when we see ECG. Okay, so we look at waves. So we have waves, we have segments, and we have intervals. Just give me 1 second. Sorry. Yeah. So coming to waves. So as we know in the ECG, the undulations that are caused in the ECG over the baseline segment are called waves, right? And you have a P wave, which represents atrial depolarization, a QRS wave, which is in orange, red, and purple, which indicates ventricular depolarization and atrial repolarization, which is hidden, and a T wave, which is ventricular repolarization, right? So we're only going to focus on waves. I'll talk about segments later. So P wave, electrical atrial depolarization or atrial electrical activity. QRS, ventricular depolarization or electrical activity. T wave, ventricular relaxation or repolarization. So as I showed you in the first ECG, this is what they correspond to. The P wave corresponds to the both atria getting stimulated. The QRS corresponds to the bundle of His stimulating both ventricles through the right and left bundle and the Purkinje fibers, and the T wave is the ventricular repolarization. So coming to each wave separately. The first is the P wave. So normally we look at P wave in the physiological lead, which is lead 2. We also look at V1. If you remember in the first diagram, V1 is on the right side of the heart. It's the only lead on the right side of the chest wall. It corresponds to the right atrium roughly. That is why we look at lead 2 and V1. So normally in lead 2, the P wave is upright. And in V1, the P wave is a biphasic wave. One representing right atrium, one representing left atrium. If the patient has atrial enlargement, if the right atrium is enlarged, the P wave in lead 2 will look tall. That is more than 2 small boxes. Normally, the P wave is about 2 to 2.5 small boxes in height. If it becomes more than 2 small boxes in height, it becomes right atrial enlargement. If it becomes more, and normally the width of the P wave is also 2.5 boxes. If the width of the P wave becomes more than 2.5 tiny boxes, we call it left atrial enlargement with the appearance of what we call the P wave notch. If both are present, you have a tall P wave more than 2 boxes and a wide P wave of more than 2.5 boxes. This is both atrial enlargement called biatrial enlargement. This is how they look in lead 2. In V1, P wave appears tall in RE. The negative deflection, which is the left atrium, becomes deeper if there's LAE, and both it becomes combined atrial enlargement. So eyeballing the P wave is something nobody does because it's a small wave. You say, okay, is it there? Then it's in sinuses. Let's forget about it. Never forget the P wave. It is the start of every cardiac cycle. So coming to the ECG, if you look at the ECG that I have shown you in this particular figure, look at the ECG. First, look at the calibration. I don't think there's the calibration mentioned, but let's assume that the calibration is normal in this case. Look at the P wave. The P wave looks stretched upward. It is about 3 boxes in height, which is more than it's normally supposed to be. This indicates right atrial enlargement. Now, what is right atrial enlargement due to? Tricuspid stenosis, Epstein's anomaly, anything that's causing a problem with the right atrium causing it to enlarge. This is another ECG. The calibration here is normal, 1 wide, 2 wide. Sorry, 1 wide, 2 height. If you look at lead V1, you will see that there's a nice positive deflection which we expect, which is equivalent to the right atrium. But look at the negative deflection. Can you see how prominent that negative deflection is? Right? So this is called the terminal wave of Morris. It's quite a prominent. This indicates left atrial enlargement. But you'll notice that it's not as wide as in lead 2. I said for left atrial enlargement, the P wave should be more than 2.5 boxes in width in lead 2. It's not that. But you can see how prominent it is in V1. That's why you should always comment on the P wave looking at both lead 2 and V. Look at this particular one. Again, you can see that the negative deflection, which corresponds to the left atrial enlargement, is so prominent here. And if you look at it in V lead 2 as well, it is more than 2.5 boxes in width. So you have left atrial enlargement looking like this. The commonest cause of left atrial enlargement are basically mitral stenosis, systemic hypertension, and MS is the most common. In fact, sometimes we have picked up patients with mitral stenosis purely based on 2 things: a loud P2 on auscultation of the pulmonary area and a left atrial enlargement on an ECG with nothing else. We have picked up asymptomatic mitral stenosis in certain patients. So it's important to look at the P waves, right? So the P wave morphology can be tall, more than 2 boxes, wide, more than 2 or 2.5 boxes, or both, where it is both atrial enlargement. This is about the P wave. Now coming to the most important complex, or the most complex, which is QRS. This slide shows the 12 different types of QRS that we can see. And this looks awfully confusing. Let me break it down for you. When you look at an ECG, okay, the first negative wave that you see, I'll just show you on an ECG. The first negative wave that we see when a patient has, after the P wave, the first negative deflection is Q, right? So you have a P wave followed by um, a negative deflection, that is Q. So every negative deflection that occurs after the P wave is called a Q wave, right? That is Q. The positive deflection which occurs after Q, the first positive deflection, is called an R. Then you might ask me, sir, what if there's no Q? It's still called R. So the first positive deflection is always R. Whether it's preceded by a Q or not, doesn't matter. The first one is called an R. The second negative deflection after R is called S, right? So it is Q is the first negative deflection. R is the first positive deflection, irrespective whether there's a Q or not. S is the second negative deflection. Can you get S without Q? Yes, but it will always occur after R, right? So this is how it looks. Can you also get a second positive deflection? Yes, it's called R dash or R prime. That occurs after S, it's called R dash or R prime. So based on that, you can either have QRS, you can have RSR dash, you can have QR without S, RS without Q, just R, or QS without R. These are the 6 most. Ideally, you have all 12 as in the previous slide, but to simplify it, these 6 complexes you have to know. Can you see all 6 in the same ECG? Maybe, but at least you'll see 3 or 4 of these combinations. So QRS, RSR dash, QR, RS, plain R, or QS are the 6 most important QRS patterns that you should be able to identify. ECG. Is the calibration okay? 1 wide, 2 tall, calibration is fine. Focus on this complex. If you focus, the first negative wave, so this is the P wave, the first negative wave after it is the Q wave. So you have a Q, you have an R, you have no S wave here. So this falls under the QR category. Now you'll ask me, sir, is Q physiological or pathological? And the answer is both. You can have physiological Q waves, especially in lead 3 as demonstrated in the figure. But if the Q wave is more than 1 mm in depth, right, it becomes pathological. So pathological Q waves, which are annotated as a capital Q, are when they are more than 1 mm in depth. So if you look at this particular ECG that I've shown you, it is definitely more than 1 mm. So this is possibly pathological. Physiological Q waves, nothing to worry. Pathological Q waves indicate dead myocardium. So post myocardial infarction, the only remnant ECG change of myocardial infarction can be the presence of Q waves. So this is called a QR complex. You look at this ECG, this wave in V2 or V3. There's only a negative deflection. There's no R wave. This is called a QS complex. And a QS complex is also indicative of a myocardial infarction. In fact, if you look at the ECG, you'll see there's ST elevation, which is becoming normal, and T wave inversion. So this is an anteroseptal myocardial infarction. This is a classic QS. So pathological Q waves or QS both indicate dead myocardium. Look at this QRS. You can see an R after the P, the first positive wave is R, the second negative wave is S, another positive wave is R dash. So this becomes RSR dash pattern. Classically, this is seen in right bundle branch block. So RSR dash pattern is seen in right bundle branch block. So this right bundle branch block can be seen in 1/3 of the population if it's incomplete. If it's complete, where it's more than 3 small boxes, it's called complete RBBB, which can be pathological in certain conditions. So RBBB is something we should easily identify. This is the next pattern that you can identify. Now, this is an interesting pattern. You have an R wave, you have an S wave, and a sort of R wave. It's not really a pure R wave, but it looks like an R dash wave. This is also called RSR dash, but this particular RSR dash pattern has some ST segment depression. And this is called Brugada's pattern. So this is Brugada's syndrome, which has high risk for ventricular tachycardia. Again, this falls under the RSR dash pattern. The next thing you look at is this large complex. This complex is not only tall, but it's also wide. So the QRS complex is normally less than 3 small boxes. Here it is approximately 4. So anything more than 3 small boxes means wide QRS. Wide QRS means there's a problem in the bundle of His or the bundle branches, left or right. This is called a R complex. So if you look at it, this is a R complex because there is no negative wave, it's only a positive wave with ST depression. This is classically seen in left bundle branch block. This type of wide bundle with a predominant R wave. Right? So this is about the QRS. So to reiterate, QRS can occur in RS R dash pattern. It can occur in QR pattern, R pattern, QS, pathological Q, or just RS. Any of these 6 patterns are present. Pathological Q wave is more than 1 mm in depth. Presence of pathological Q wave or QS indicates myocardial infarction. RSR dash indicates right bundle branch block. Tall R wave, which is wide, especially in V5, V6, means left bundle branch block, which I'll come to subsequently. So all these patterns can be seen in the same ECG. So very important to know that you will make out these 6 ECG patterns. T waves. We finished P, we finished QRS, now we're in T. Now T waves have a lot of morphology changes, right? Some of which are significant, some of which are not. So the normal T wave is not symmetrical. The normal T wave is actually asymmetrical. It has a gradual upslope and a rapid downslope. So non-specific changes are, if the T wave is biphasic, we call it non-specific. The T wave can be notched, non-specific. It's a slow rising T wave, again, non-specific. Flat T waves, non-specific. These are changes which you need to follow, but not necessarily need to do anything about. But if you see the T waves on the bottom, tall symmetrical T wave, which is more than 1/3 the height of the QRS, is called a tall T wave, which could be hyperkalemia. A broad T wave with ST elevation, repolarization variant, ERPS. Deep T wave inversions, myocardial ischemia ongoing, not infarction, ischemia. Inverted T waves with a downslope is strain pattern, which means the ventricle chamber is enlarged, and because it's so enlarged, it is being strained. The T is stretched and pulled out. This is called a prolonged QT interval, classically seen in calcium, hypocalcemia. So these are abnormal T waves which you have to pick up. You have to know the patterns. Tall T waves, which are symmetrical, T wave inversions, which can be ischemia or strain or prolonged QT. You look at the ECG, this is classically a patient undergoing hemodialysis. Look at how tall these T waves are. Tall, symmetrical, they look like a tent, classical of hyperkalemia. This needs urgent hyperkalemia correction. Now these T waves, if you look at it, they are also tall, they are also symmetrical, but they are not narrow, they are broad. This is called a broad tall T wave. Classically, this is seen in acute coronary syndrome. Now you may wonder, sir, acute coronary syndrome MI has ST elevation or ST depressions? Not really. The first sign of an ST elevation MI is not ST elevation. It is a tall symmetrical T wave. The number of medical students and the number of bonders who sent me ECGs over the last 6 years that I've been in Johns with tall T waves and saying, sir, it looks normal, no? And I think to myself, either there's hyperkalemia or the patient is having acute MI. And I can remember at least 5 or 6 incidents where I've told them, is there any risk factor for hyperkalemia? No. Dialysis? No. CKD? No. Chest pain? Yes. This is a tall T wave suggestive of possibly myocardial ischemia. If the patient is having ongoing chest pain, repeat the ECG and refer them. And there are 5 or 6 occasions that I can remember where I have unfortunately been right. And it has turned out to be an MI, but we've saved the patient purely because you are able to identify. So never misread or overlook a T wave. If the T wave is tall and symmetrical but wide based, it could be evidence of acute MI. Tall, symmetrical but narrow based, hyperkalemia is your most likely types. Okay, very important. T wave inversions. This means there is myocardial ischemia, not death, ischemia, which you have to work. This is how non-ST elevation MI can present. Classic biphasic T wave, again suggestive of NST MI can present with this type of T wave presentation. So you've covered biphasic T wave, I've covered T wave inversion, I've covered tall symmetrical narrow, covering all the types of ST T wave inversions that you see. One wave I want to bring out, which is one of the waves that some of you may pick up in ECGs, and I was very impressed with, I think, 2000, somebody from 2016, I'm not going to mention names, but somebody from 016 sent me an ECG of their patient. Absolutely normal ECG, came for fitness for cataract. Sent me an ECG, put an arrow and said, "Sir, I think this patient has Wolff Parkinson White." And I was so stunned because the diagnosis is absolutely correct. If you look at the arrow that I've put, you can make out that there's a slight upsloping to the QRS. Slight. It's very subtle. And this is the delta wave of Wolff Parkinson White, right? And something that needs to be evaluated, as you all know, because it can lead to life-threatening arrhythmias. So this is one extra wave that you see. Last part of today's class, segments and intervals. And again, something that I find is very much overlooked by a lot of students, because you look at the ST segment, it's not ST elevation MI. I don't need to refer the patient. I can give symptomatic treatment and stop. No. Segments in ECG are dynamic segments because all the segments that you see have to be isoelectric. They have to be flat. That is the PR segment, that is the ST segment, they have to be flat. If there is a change in they go up or they go down, both are dangerous. So just saying, oh, the ST segment look normal to me, no MI is not enough. ST segments can be indicated of ischemia, not necessarily MI. They can indicate drug toxicity, they can indicate hyperkalemia, they can indicate hypokalemia, they can indicate early repolarization syndrome. There are a lot of things that you can pick up in the ST segment, not necessarily just MI. So let us pay attention. This is a standard ECG, PQRST. Intervals and segments are different. Intervals represent time taken for impulse to be conducted to some part. So for example, PR interval, beginning of P wave to beginning of QRS complex. PR interval is the time taken for the SA node to stimulate the ventricles. That is SA node to AV node, how long it takes from St. John's to Silk Board Junction. Same way, SA node to AV node to the ventricle is PR interval. Start of P wave to beginning of QRS. This indicates SA node function. It indicates the pathways which connect SA node to AV node and indicates AV node transmission to the bundle of His. All are included in PRA. You look at the ST interval, not ST segment. I'm talking about ST interval. It's from the end of the S wave to the end of the T wave. This is the time taken for the ventricular relaxation to complete, for all impulses to settle down. Not a very important interval for us. The most important interval for us is QT. QT is the time taken from the beginning of the Q to end of T, not beginning of T, end of T. And this represents AV nodal stimulation of the bundle of His, right bundle branch, left bundle branch, and ventricular repolarization. So QT basically encompasses the whole ventricular electrical activity and repolarization both. So this is a function of electrolytes, especially calcium and potassium. It is also a reflection of the ventricular electrical capacity. So there are only two intervals, PR, which is SA node to AV node, and QT, which is AV node henceforth. Two intervals are important for you. Segments. The most important segment in medicine, the ST segment, right? So the ST segment is the most important segment. I'll come to that. But the PR segment and the ST segment are isoelectric. Isoelectric means they are flat lines. They're also isoelectric because in this segment, there should be no activity. There should be no undulations. If there is an elevation or a depression, it indicates ongoing vascular compromise. So if the ST segment is elevated, ST elevation MI. Depressed, non-ST elevation MI. If the PR segment is elevated, atrial MI. If the PR segment is depressed, pericarditis. So PR interval segment and ST segment are normally isoelectric, should not be up or down from the electrical baseline. I'll come to that in each. This is the PR interval. Beginning of P wave to beginning of QRS complex reflects conduction from atria SA node to AV node. Normally, this is not more than 5 small boxes. 0.2, some books say 0.21, 0.2 seconds. It should be ideally 3 to 5 small boxes. But now it should not be more than 5 small boxes. So if you look at it in this space, it is approximately 7 to 8 boxes. So this is a prolonged PR interval, which means there's some problem in conducting from SA node to AV node and from AV node to the bundle of S. That gives you that impression. So if you look at this particular slide which I've shown you, you will see that the PR interval in successive is changing. Here it's approximately 3. Here it is approximately 5. Here it is 7. Here it is approximately 17 boxes. In fact, in the last one, there's no QRS. There's directly P to P. There's a missed beat. And this is basically AV block. This is probably Mobit's type 1, type second degree AV block. So you'll see here how the PR interval keeps varying from complex to complex till one beat is missed. If you look at the ECG on the bottom, that is how complete heart block looks. Again, sorry, this is type 2 Mobit's. Mobit's type 2. PR interval is about 5 boxes, suddenly skips a beat. 5, 6 boxes, 5, 6 boxes, skips a beat. So this is Mobit's type 2, this is Mobit's type 1, indicative of AV block. In the next ECG class, I will teach you all about it. This is the PR interval. Look at the PR interval. This is at least about 12 boxes. This is along with ST elevation in 2-3 AVF. This is an inferior wall MI. Commonly, inferior wall MI have complete heart block or AV blocks which present. Coming to the QT interval. The QT interval is from the beginning of the R wave or the Q wave to the end of the T wave, right? So this is the QT interval, and roughly it's about, it varies. So the QT interval, we have a calculation where we use the corrected QT interval or Bezet's formula, where we do QT interval divided by the square root of the RR, heart rate, I'm sorry. So QT divided by square root of the heart rate, and it gives Bezet's formula. So anything more than 45.45 or in a woman and 0.47 in a man are abnormal. But these numbers are difficult to remember. So roughly, you take the RR. If your QT is more than half the RR, if the QT is roughly more than half of the RR complex, you can say it's prolonged. Otherwise, you manually sit and count each small box. If it crosses more than 12 small boxes in a man and 10 in a woman, it is prolonged. So here it's approximately 13 or 14. So this is prolonged QT, classically seen in hypocalcemia. This is the opposite. This is short QT. Can you see how close the QT is? This is short QT, hypercalcemia, and you have some short QT and long QT congenital genetic syndromes, which they would have taught you in pediatrics. Coming to the most important, which is the ST segment. The ST segment, as I mentioned, is an isoelectric segment, which should be flat. You have ST segments, which can be ST segment elevation and ST segment depression. So this is how ST segment elevations look. Now, this is the most important part of today's class in a way, because this is the most critical part of the ECG that you need to diagnose. Now, the ST segment can go up and the ST segment can go down. ST segment elevations are what we'll deal with first, where instead of the ST being in a horizontal line, it is pushed up. Whenever you see ST segment elevation, it means ST elevation MI. So this, and these are the 4 ways in which it can go. It can be convex upwards, straight upsloping, straight horizontal, straight downsloping. All indicate ST elevation MI. And this is how they will actually look when you look at an ECG. So this is ST elevation, convex upwards, horizontal, this is upsloping, and this is mild ST elevation. All 6 ECGs are evidence of ST elevation MI. So please remember, ST elevation MI doesn't always need to look classical. It can be as subtle as this, it can be as obvious as this. It's important to know. But can you get ST elevation in a condition which is not MI? Yes. This is called non-ischemic ST elevation. So if you look here, it is concave upwards. And this may be seen in patients who have left ventricular hypertrophy, young patients with thin chest wall, early repolarization syndrome, pericarditis. you can have ST elevation, which is concave, versus convex, which is evidence of STEMI. So how do you identify this? I know it's very easy to say. Let's look at a few ECGs. If you look at this ECG, you can classically see ST elevation. The ST segment is supposed to be here where my laser pointer is. It is much elevated. This is how ST MI looks, ST segment elevation MI. In the same ECG, you can also see ST elevation, which is looking horizontal upslope in AVL. So the same ECG, you have two different patterns of ST elevation. You also have ST depression. These are called reciprocal changes, which I'll teach you in the next class, which is ST depressions. This is classical anteroseptal myocardial infarction. Look at this. In this ECG, you can see that there is very, very subtle ST elevation in this particular lead. The same ST elevation is also occurring in the lateral leads. Now, when you look at this, you are worried. Okay, sir, this is ST elevation MI. I need to rush this patient to a PCI, for thrombolysis or a PCI. Answer is no, because this patient actually has concave upward ST elevation. And whenever you see concave upward ST elevation, it is non-ischemic ST elevation. And in fact, this is called J point elevation. The most common ECG I get is this one. Sir, this is ST elevation MI. Shall I thrombolyze? Shall I load them with antivirus? My answer is it's J point elevation. Tell the patient to go home unless there's ongoing ischemic pain. And you get shocked. I've had students who call me up and said, sir, you said J point elevation and not STMI? I said, yes, because the J point is at the starting of the ST segment. In some individuals, the J point can get elevated physiologically, and it can look like this. This doesn't mean they're having MI. It is just a physiological ST segment elevation. Now, if it's there with acute chest pain, sweating, etc., obviously I would worry. But if it's there in a routine ECG, this indicates early repolarization, ERPS, early repolarization syndrome, which is basically a benign abnormal electrical activity in the heart. So it's extremely important that to differentiate ST elevation MI, which looks like this, from J point elevation. That's why I put up all three charts. Concave upward versus convex upward. See the difference in the two? It's very important that you identify the difference between concave upwards and convex upward. Concave is benign, convex is pathological. If you can identify J point elevation, you will save a lot of patients being run to a heart center, you're having heart attack, run. Right? And then they go to the cardiac center and send back saying you got gastritis, go back home. Right? Identify J point elevation. These are all the patterns that you see. We're coming to the last couple of slides in this class. I know everybody's attention is waning. ST segment depression. ST segment depression means that ST segment, which is supposed to be in the dotted line, has come down. It can be upsloping, it can be downsloping, it can be horizontal. Okay. Now, if you see an actual ECG, this is how it looks. So this is ST depression, classically seen in 2-3 AVF. This is classically horizontal ST depressions. The next slide, this shows classical, this is ST segment depressions. Now, what do ST segment depressions indicate? ST segment depressions indicate that the patient is having ischemia or infarction. So the patient can have unstable angina with this or non-ST elevation MI. So STEMI is ST elevation MI, ST is elevated. If ST is depressed, it becomes NSTEMI. Is NSTEMI an ACS? Yes. Does NSTEMI require referral for cardiac evaluation? Absolutely. NSTEMI can be as bad as STEMI and have as bad outcomes if not identified early. So if you look in this patient with the V3, you can see the significant ST depressions here. So never neglect ST depressions. Can you get ST depressions in conditions apart from MI? Yes. In severe anemia, where there's or severe hypoxia, you can sometimes see ST depressions, but it's always indicative that there is some myocardial strain requiring urgent evaluation. So never believe ST segments are less dangerous than ST. Depressions are less dangerous than ST elevation. Never believe that. ST depression is as important as ST elevation to identify myocardial infarction. I thought we'll have 5 practice ECGs to wind up the session to show you what can go wrong. This is to focus on the axis. Lead 1 negative, AVF positive, AVR positive. Can anybody unmute themselves and tell me what the diagnosis is? Dhwani, go ahead.
Sir, wrong placement of leads.
Why not dextrocardia, Dhwani?
Sir, AVF is always negative. Sorry, AVR.
Yes, so here AVR is turned positive. Now I am saying this is dextrocardia. Dhwani says it's wrong placement of leads. The nurses have misplaced AVR and 1. If you compare to the earlier ECG which I showed, Dhwani, V5, V4, V5 ECGs, the R waves are becoming bigger and bigger, which is normal. In the ECG I showed, V4 to V6, the ECGs became shorter and shorter and shorter. That told me that is true dextrocardia. This is called technical dextrocardia or doctor and nurse dextrocardia, which is because we've connected the wrong leads. This is technical dextrocardia. You just reverse AVR and 1, you'll get a normal ECG. So don't label, oh, this is right axis deviation. Chaitanya sir said right axis deviation occurs in dextrocardia, cor pulmonale, and in cor pulmonale and dextrocardia. So therefore, this is abnormal ECG, needs referral. No. This is just a technical error where the AVR and 1 have been interchanged. Second ECG, I want people to identify this and tell me what the heart rate is. Anybody wants to volunteer can raise their hand, apart from Dhwani, of course. Anyone? Can unmute and try. Yes, go ahead, Veena.
50, sir.
Very good. So if you look at the RR interval in lead 2, the calibration is 2 tall and 1 wide, which is normal. If you calculate the number of big boxes between the two R waves, you're right. There are about 6 big boxes, 6 or 7. So 300 divided by 6 is approximately 50. So bradycardia. And if you look at it, you can see some T wave inversions where the arrows are. What I'm also trying to focus on is a U wave. So when you have bradycardia, you can also have U waves. U waves are small positive waves after the T wave found in V2, V3 physiologically. They become prominent in patients who have bradycardia or hypokalemia. So this is the patient who has bradycardia with T wave inversions. Good. Anyone wants to tell me all the findings in this? Anybody else can put up their hand and volunteer, please. Anyone? Don't make me call names out like I used to in your Zoom classes during COVID, then nobody bothered answering. But anybody wants to volunteer? Okay. So if you look at the ECG, there are 4 findings which I've highlighted. Massive ST elevation. This is called tombstone ST elevation. You can see how tall the ST segment has become. It should be here. It's raised by at least 15 small squares. So ST elevation in V1 to V5. ST elevation in 1, there's a smile ST depression in AVF and a prolonged PR interval. This is classically massive anterior wall myocardial infarction. It also involved in the anterior wall and the lateral wall with reciprocal changes in the inferior wall with a first degree AV block. Don't worry, there's a separate class on MIs which I'll come with, but that is going to come up. This is how massive MI looks. I've shown you the ECG before for prolonged PR interval. What I'm trying to focus on here is in addition to the PR prolonged, which is showing you PR interval prolongation, you have ST elevation in 2, 3 AVF suggestive of an inferior wall MI. But you'll also notice reciprocal changes from V1 to V3. This reciprocal changes from V1 to V3 indicate a posterior wall MI. So inferior wall MI can also accompany with a posterior wall MI because both are supplied by the right coronary artery. And this has a very poor prognosis if you have both inferior and posterior wall MI. These are called reciprocal changes. And the last ECG for today, which you can identify, is if you look at the bottom, which I've circled and here, these look like T wave inversions, right? These look like ST depressions, sagging STs, as they call them, and certain T wave inversions. But this is actually what you see in hypokalemia. You see sagging of the ST segment, T wave inversions, TU waves. So this is actually classically what you see in hypokalemia. It looks like the QT is prolonged. It's actually a pseudo QT prolongation. This is actually a QU. It's actually a mixture. It's actually a TU wave. So there's a mixture of a T wave and a U wave here. That's why it looks like the ST segment is pulled down and stretched, classically seen in hypokalemia. So with that, today's ECG session is done. I just focused on the basics today, so hoping that all of you would be able to understand how to interpret an ECG. I would share my PPT, of course, once the second class is done. Go back, Life in the Fast Lane, whatever book you want to read, how to read an ECG, right? Goldberger, if possible, is a very good book to read. Just need to understand how to read an ECG. Follow the checklist, follow the order. Calibration, rate, rhythm, axis, waves, intervals, and segments. Then is interpretation. Never try and do the fast forward jugaad that we all do, is to skip it and come to a final diagnosis. The fancy thing that you guys would have seen me do in the ward. I just pull the ECG apart. Oh yeah, this is atrial fibrillation. That comes after reading about 5,000 ECGs. You have to go in that order. Only if you go in that order, you will never ever miss any abnormal findings on an ECG. So I'd be happy to take any questions if people would like.
You can put up the questions in the chat box. I've also put up the feedback form. You can start filling that up. Oh, people are putting thank you. So no doubts, is it?
Either they've understood, as every teacher before me has also said, and every teacher told me, either they've understood everything or it went over their head.
Or they've not understood anything.
I don't understand, but I'm going to give myself a little credit and say maybe they have understood, and hopefully they will reach out to me.
Yeah.
You can always reach out on the WhatsApp group, and any doubts, I'm always available. Send me the ECGs. I think this is something that I never had as an intern or as this one, to have somebody to send ECGs to, because nobody would bother replying at that point of time. So I had to read on my own. So you guys have all of these at your fingertips. So please use all the resources. And thank you to Teach and Learn and Navneeta for this. I think this is such a lovely initiative, and it's so important for all of you. I mean, I don't know very many medical colleges which get the amount of help and teaching that St. John's does. It's a beautiful place to be part of, and all of you are always going to learn, and all of you always help. Whoever you want to reach out to, there's always somebody to help you out. I think that makes a big difference in this big mean world that we all have.
Yes, sir, I totally agree with you. Thank you so much for joining. And thank you all for joining in on the weekend. I hope you found this session useful. I remember, sir, taking this class during my final year during the COVID days. From that time onwards, till date, I can say that I'm using this method to read all my ECGs. Right now, I know it feels a little time consuming because you have to go through all the steps, but it does get easier, and you'll be able to read the ECG faster. So I would urge everyone to start familiarizing with this method, and so that it'll be easier for you during the next session when sir discusses more complex ECGs. I would like to extend my gratitude to Dr. Chaitanya sir for this amazing session. Thank you for dedicating time.
Anytime. Thank you so much.
I know that one thing about sir is that he actually never says no to any teaching session. However busy he is, he finds time. So thank you so much for that.
Always.
And yeah, we'll be soon scheduling the part 2 of this webinar, and probably not this week, maybe next week or the week after that. I'll be posting about it soon. A few things before we end the class. Feedback form again. I have put it on the chat box, and I'll be putting it up in the WhatsApp group as well. Please fill it. I really think you should do that. You have to give sir the review that he deserves, and also put up anything that you want us to improve for our next session. Also, we have discussed that for the next session, we are okay to discuss a few ECGs if you want us to do that. So I can put up a link wherein you can upload the ECGs pictures that you want us to discuss for the next class, so that after the class we'll allot some time to discuss those ECGs. And all the speakers are being added to the WhatsApp group. You can ask doubt, any questions regarding the classes, and during your bond, or anytime that you want to, anytime that you have any questions. Recordings will also be uploaded on the YouTube channel, but we'll not be uploading this until we finish the part 2 as well. So kindly, please attend the next class as well. We will be uploading the sessions after a few weeks. Once again, thank you so much. We'll meet you all for another session.
Thanks, Nimita. Thank you, everyone. Take care. Bye-bye.
Bye bye. Thank you, sir.